Hi, Justin. Can I?
Hi, so are we live?
Yep.
All right, well, welcome everybody. I can't really see who's here and who's not here, so I'll just go blind. You have myself, Justin Farahi from Farahi Law Firm, and the wonderful Dr. Sharieff, Neuro-Optometrist. We're excited to hear where the lines are between optometry and neurology and where Dr. Sharieff kind of dives in the middle. So, Dr. Sharieff, if you could dive into the material for us.
All right. Can you hear me well?
Perfect.
Okay. So just to kind of reintroduce myself, I know you used the word neuro-ophthalmology, but you did say optometry and neurology. So just to rephrase that term, I'm a neuro-optometrist, and this is a fairly new term. Um, Newer in the sense it's been around for at least a couple of decades, but mostly in the rehab world, in the hospital settings. So may not be common knowledge, even with the regular physicians out there, they're learning about it. It's becoming very, very, very popular and well known today nationally, but it's still very far from being common knowledge. So I'm going to have to introduce that term a little bit. Once again, my name is Kauser Sharieff, and I practice in Orange County in Yorba Linda and Tustin. And to jump right in, let's see, what is neuro-optometric rehabilitation? It's basically functional vision evaluation for people with neurological dysfunctions. So I started out actually doing in-service in hospitals where people have had stroke or traumatic brain injury, more severe ones, and then transitioned or added the concussion piece. So I'm part of a Orange County Concussion Consortium also. So neuro-optometric rehabilitation is, as you will learn with the slides, further down, it's not the eyeball that we are evaluating and treating, because in a concussion or brain trauma or stroke, the eyeball itself is not touched. It's not affected physically, structurally. What's happening is the eyeball is connected very intimately to the brain. And a lot of those connections are disrupted, and it causes a huge upheaval in the person in terms of how they see the world, how they move around, how they track, how they understand, and how they function. And vision being our dominant sense, it actually interferes with everything that they do. So that's why this field has become so popular and needed, especially in the hospitals. And just to give you an overview about that, I not only do evaluations and treatment in my offices, I actually also go to inpatient evaluations at UCI Medical Center, at Health South Testing Rehab Hospital, and some other hospitals. I work very closely with neurology, the rehab team, speech, physical, occupational therapy. So who are the candidates? Anyone with a stroke, traumatic brain injury, developmental disorders, concussion. Concussion is considered an MTBI, as you all may know already, mild traumatic brain injury, but surprisingly, the patients have actually a lot more symptoms, and they seem to be more vocal about it than even the most severe strokes. And they're much harder, not harder, I should say, but a lot of maintenance in order to really help them cope with that symptom. Now, the eyeball is about here, and when you go for an eye exam, this is a visual tract here, and the occipital lobe, that's where we see clear. And basically, this is all that gets evaluated in a regular eye exam. The shape, the contrast, I mean, we're getting glasses or contact lenses, and typically everything else, we take it for granted because it's all working well. Well, guess what? In a TBI, actually, we need to take into account vision is processed in every single lobe of the brain. The frontal lobe does, eye movement planning. It's really like, where do you start and where do you end, like where you're landing in space. The parietal lobe here on the top, visual spatial map, visual attention, that can get disrupted if they have any issues in this area. The temporal lobe is motion perception and object perception. Those are the temporal lobes. We already talked about the occipital. And down here are the eye movement control centers, you know, the midbrain, the cerebellum, and the brainstem. They coordinate with our other senses, the vestibular and the auditory, and then they actually seamlessly allow us to function, you know, normally, efficiently. And in a TBI, all of these areas can get disrupted, finer connections, and that's when people have, they feel like not their normal self, because now things have changed compared to how they were used to understanding the world and processing efficiently, multitasking. Everything was working seamlessly, and it doesn't work anymore because those connections, there's a lot of potholes that develop, there's a lot of detours that's going on, and things are just slower for them. And just like how, you know, people undergo physical occupational therapy, vision is the same thing. You know, everyone's heard of neuroplasticity. So in the cortex, you know, vision is, because it's everywhere in the brain, there is plasticity in vision, and definitely we, you know, there are things that we're able to improve. Once again, I'm not talking about the eyesight or the eye structure because that's not affected. So, but the eye coordination is affected. So they may need prisms and they may see blurred. Also, this is the condition that is very undiagnosed and untreated because it's not overt, you know, like balance and motor problems, or in more severe cases of trauma, hearing and speech can be affected when they have a stroke or any other injury that's a very severe traumatic incident. But vision problems, looking at someone, you can hardly tell if they are having depth perception issues, if they're not tracking well, if they're seeing double. Unless an eye is turned way out or something, you really can't tell. And that's why these conditions are completely overlooked and they're missed.
Dr. Sharieff, there are some questions that we have, and I want to start with the basics. What is visual plasticity?
What is visual?
Plasticity. Can you explain,
So,
because nobody's, you know, for the most part, it's not going to be doctors here. It's going to be lawyers, and this may be an introduction for them. If you could dive into that.
right. So when I explain the conditions that are affected, those are the conditions that can be improved and changed. So plastic means something that can be changed, okay? For example, eyesight, okay? That one is more structural, and it's not something you can change it in a matter of weeks or months. But the other parts of the brain that allow us to track and be able to know spatially how we are and depth perception, those are some of the things that we are able to change. So plasticity just means that the brain is able to improve and change, just like how when you want to learn a language. I mean, even when you're 50 years old, if you want to learn a language, we can. You know, we can definitely change our brain to learn a new thing because our brain is plastic. So the term neuroplasticity just means that the brain has the ability to change. And there are various aspects of vision that allow us to improve a person's skill level that will allow them to be able to overcome, you know, the post-concussion syndrome. So I'm going to go through that on this slide, and it'll be a little more clear what I'm talking about. Okay?
Okay, so as you go through this slide, again, the questions are pouring in, and I just want to make sure that we answer questions at the same time as the presentation is. As attorneys go through their cases one by one and do their intakes, and let's say, you know, the client says, feeling of overwhelm, trouble seeing, decreased ability to concentrate, poor visual, short-term memory, things like that. At what point, you know, if they check boxes, right, and they see that their client has specific issues, at what point do they go to an ophthalmologist? At what point do they go to the neurologist? At what point do they go to a neuro-optometrist or ophthalmologist?
Right. So usually if in a concussion situation, a lot of times they are evaluated initially by a physician, for example, a neurologist or a family doctor or a sports medicine doctor, just to make sure they don't have any physical structural damage. So they may get an MRI, a CT, or they can just be observed if it is not, if it is just a rear-ended situation, you know. So physically, they're usually cleared by the time they come to, and they're having persistent symptoms. So say, you know, the patient goes to, usually they're under the care, they go to the ER, for example, and after an accident, and then there they may get some clearance and say, hey, you're physically okay, just go home and rest and you'll get better. Well, you know, a lot of, so they're basically clearing you for any structural damage. But 2 days later, 3 days later, they realize they're completely overwhelmed with all the symptoms, correct? So once they're physically cleared and they're having these symptoms, that's when they come to the neuro-optometrist. So they can come to us a week out or a month out, and sometimes we get patients even a year out and they're having these persistent symptoms. So typically, my typical concussion patient, I'm getting my referrals from a physician saying that we've looked at this patient and they don't have anything physical going on with them in terms of, you know, like bleeding in the brain or whatever. They've just been cleared physically, and then, but they're having all these persistent symptoms. So typically they come directly to me. Even when I go to the hospital, they're under a neurologist care. So usually an ophthalmologist is in my, you know, co-management situation. An ophthalmologist is usually not involved directly unless there is a physical damage of the eyeball, you know, that actually have an eyeball structural damage. Usually they're cleared by a physician and they're having all these symptoms. So whenever they have these symptoms, they can come and see us, you know, as long as they've been cleared a week out. So we have a form, it's called the post-trauma vision syndrome, that lists all of these, um, you know, symptoms on it. And we have a grade from say 0 to 10. And if they're grading things above a 3, you know, then we can help them. You know,
Okay.
they're not getting better.
So
So
follow-up question. You said you get most of your referrals, or yeah, I should say prescriptions, right? You know, a referral prescription from a primary care, or do you know, see it from a neurologist, or who generally is the person that refers the patient over to you?
um, a lot of sports medicine doctors, a lot of neurologists, a lot of physical therapists, occupational therapists, anybody in the rehab world, or anyone who has knowledge of concussion, or attorneys that we worked with that understand, you know, a lot of neuropsychologists also. And I will go through towards the end of my presentation a screening tool that anybody can use, anyone. And in 5 minutes, people can refer as long as they've been cleared medically.
Okay, so now
Does that make
question
sense?
number 2. So we have the people that refer to you. You said neurologist, primary care, sports medicine, neuropsychs. They refer over to you. Now, who do you generally refer your patients out to after your consult?
I just give a report back to whoever, you know, is referring the patient to me. If they're going back there for continuity of care, I'm more of a specialist. So once I get the patient and I finish my, you know, evaluation, and if we need to get approval for treatment, you know, we send a report back, if it is an attorney, just to make sure that they're okay with, you know, the report, and they're okay with the further treatment, and we continue on to the treatment. We also, if it's a physician, you know, and they're going back to that physician, then I send them a report as well so that there's continuity of care.
Okay, beautiful. And last question I have from the audience, which I'm going to say I think is the most important question. Do you work on a lean?
Do I work what?
On a lean.
Yes, I have been.
Okay, fantastic. So I think that's it for me. I'm going to kind of fade away until the next round of questions come up.
Okay. So all the symptoms that you just read out, all of these things in red, light sensitivity, dizziness, headaches, neck, shoulder pain, just diplopia or trouble seeing detail, so they know that something's not right, but they don't know exactly what it is. They know for sure that things are not the same. They can also have other symptoms. When attempting to focus, they lose the visual field awareness. And because things are not what they're expecting, they have a panic feeling or anxiety that actually makes it even worse. And they have like a tunnel vision almost. And then that makes their ability to maintain their balance, on all that difficult. They have difficulty multitasking, like I said. There's timing issue, lack of fluidity of motion, balance, coordination. Objects in space, appears to move, or movement appears to be strobe-like. You'll be surprised at how much these people are affected. And they're expected to function normally, and people think they're just, malingering, but actually there are specific things that we can detect with our testing. So that, the symptoms feel like an overload, right? But when we evaluate them, we have specific tests that we evaluate the visual field, we evaluate their eye tracking, different types of tracking called pursuits and saccades and nystagmus. So I don't want to get technical, but all the, strabismus just means their eye coordination is off, their
So
convergence is off.
sorry, can I ask you a question on this? Do you do more are they objective tests in a sense? Are they done by hand? Are they done with a machine? Just generally, if a patient is being sent to your office, what should the patient expect in terms of the testing that will take place?
So we try to do as much objective as possible, subjective symptoms for sure, but we like to document and have a reference for us. So wherever possible, we try to get an objective measure. We do just maybe gross evaluation, but then I have slides to show you, that we actually have testing that we can record and have objective data.
Okay.
Okay. So, so basically, without going too much into technical details, they're focusing, their ability to like make sense of things, perceptual, skills, and we even have testing about their balance that I'll go into. So these are all the objective and the subjective tests that we have. And even though I have a lot of symptoms on the previous page, and we are like, where do we start? Fortunately for us, we have ways to evaluate these things. So we feel at least 90% of those with neurological injury, have visual function changes. And unfortunately, it's not diagnosed, it's not addressed, and people are suffering quite a bit. Now, when I do this in person, I can show that vision is our dominant sense truly. I usually have people put on these prism glasses and I have them run their hand over like a edge of a door. Without it, they say, okay, this is straight, it looks straight, it feels straight. When you put these prism glasses on, it actually distorts their vision. And when they rub their hand over the door, again, the edge, because it looks curved, guess what? It feels curved to them. Believe it or not, this is dramatic. So unfortunately, this setting, I cannot have anybody participate or experience, but this is dramatic. I'm gonna go over this a little bit later, but your vision overrides your sense of hearing. And this is called the mcgurk effect. And I wasn't able to get this to run on this PowerPoint right now, but I'm going to try a little bit later to see if I can demonstrate that if you don't look at a person talking and you're just hearing, honestly, you can get the wrong message. And this is powerful. So if I don't get to it, you you can Google McGurk effect, McGurk, McGurk effect, and you will be amazed that you need your vision in order to get the right information. So we're not talking about just the structure. So damage to structures, the brainstem, cortex, cerebellum, I showed you. There's also something called the neural pathways. I just wanted to introduce that to you because there's a lot more going on in the brain than actual physical structures. There is something called the primary pathway, the dorsal pathway, like where is that object, or what is it, the detail, or where am I in relation to something else. So there's all kinds of things that need to be in place. I'm just giving a very, very, very broad overview that we look at a lot of things. It doesn't mean we ignore the structural problems if they have a dry eye, eyelid issues, something going on, diabetic retinopathy, for example, cataracts, glaucoma, right? So we have to make sure that we are ruling out anything that may be influencing their symptoms, which may have been ongoing, but we still need to know how much of that is affecting their symptoms, and we need to make sure we separate that out from their actual brain injury and symptoms due to that. So we definitely, I dilate all the patients and I make sure that I know exactly what's going on. I know what their prescription is. I know how their external eye looks. I know what internally that eye looks. I do a retinal image. So I really have to make sure I rule out, anything physical before I jump into my more functional evaluation. Everybody's familiar with visual field defects. That's the, where you can have actually your brain, really damaged, or where you lose part of your vision. We see this mostly in, actual serious trauma patients or stroke. Very rarely do we get an actual damage with the concussion unless they've actually had a serious car accident. But we obviously need to know if they do have a visual field, defect, so that we can address it with prisms to make sure they get the maximum out of the available field available to them so that they're not hindered in driving and things like that. We have pretty amazing tools and prisms to help people with that. And just want to make sure that people understand that a lot of TBI, brain trauma patients, concussion patients will not be needing low vision aids. And this is important to know. This is when the eyeball is structurally damaged and they cannot see or form a clear image. So we may use for diabetic retinopathy and stuff, they may just need magnifications. So TBI generally, they don't even know where the page is or where to track. So the low vision aids is not the thing for them. So I just wanted to make sure not only what we do, but what we don't do for these patients. So that's why I had to put this slide in. So this is for a very, very low level patient that has had a stroke and doesn't even know the numbers and the letters. So we might have to show tracking for them. So we may use something like this. So this is not for a regular TBI or a concussion patient, obviously, but that's the prism on the top here, right here. So we may put that on glasses if they need any eye coordination issues or double vision. We put it on their glasses, depending on what's needed. And so we actually do therapy, but that was just a brief thing. Just to let you know that there are 12 nerves and in our cranial nerves, and 8 of the 12 are related to vision. And so it can be a huge, huge, huge impact when the brain is affected. And I needed to kind of stress a little bit on the fourth nerve because this is so common, it's unbelievable. In any trauma case, we actually see like a vertical misalignment of a lot of the objects. So they have subtle double vision that is easily missed, and this causes severe symptoms in these people. They can feel dizzy, they have double vision, their eyes are fatigued, they have disorientation, they can't do near work. I mean, this is something that is also very subtle, and a lot of times, these conditions, when they're addressed, at least gives them a little bit of help immediately with some prism, but then we help them to overcome it with therapy down the road. Now, this unilateral spatial attention, again, for more severe brain trauma, who've had an actual serious car accident, believe it or not, they're unaware of things. It's different from a field loss, but it's kind of similar because it is so dramatic, it's unbelievable. If you have them draw a diagram and copy, honestly, they'll just do one side. We see like people, they may shave only one side of the face. Give them food, they may only eat one side of the plate because even though it's there, they are not aware of it. So this is different from a visual field loss, and this is more for the serious trauma patient, not from like a mild concussion or rear-ended. I just need to introduce two terms called ambient and focal vision. The best way for me to put this in perspective is ambient vision means our primary vision, visual sense that coordinates with our vestibular and auditory systems to help with being grounded and also to help with spatial orientation. So there's like a part of our vision that coordinates with our other senses in order to give us that sense. And believe it or not, this is most often affected, and it's not structural, it's functional, as opposed to focal vision, which is not really affected. So the prescription part, of course, people need to see clear, and they may have had issues all along, a little bit of prescription that they've never gone to for an eye exam and they never had it, but now all of a sudden everything is blown out of proportion, that everything seems horrible and everything seems affected. So they will need a prescription even though they've ignored it in the past, but typically that's not affected in a TBI, but we can't ignore it, obviously. We have to address everything. So they may need, definitely the glasses, but they most importantly, they'll need, most often than not, they need prism to help them with spatial orientation, with eye coordination, with depth perception, with so many things. So they end up needing some sort of glasses to help them deal with things. The bottom line is the focal and the ambient systems, there needs to be a balance. And what happens in a TBI, this is off balance. I mean, their ambient system is completely disrupted. They become very focalized and they're just like looking at one thing or another or another. They're not getting the whole picture. And that's why they feel overwhelmed because they can't take a lot of things into account at the same time and prioritize and act upon it. They're just taking care of like one single thing, one single thing, one single thing. And things, their world seems disjointed. And this is so easy to see in a patient who's had a severe brain injury, that unless you work with a patient who's really been affected, it's difficult to know. But once you see that, it's unbelievable how the brain processes information and how they're affected. So that experience has helped me understand and deal with the concussion patients. And when they're telling me and explaining things, I can know exactly how they're affected and disrupted. Whereas if you've not really had that experience, they may just seem words to you, and you may not really think that they're telling the truth, sometimes, because it may seem like out of place with what they're saying. So we call a term called post-trauma vision syndrome. All that it means is this: we see like a, a series of things that are affected when they've had a TBI. And I've just shown you some example that they're not actually seeing two things, but they can sometimes see like things aren't just together, and their eyes are constantly having to readjust and refocus. So they may say, I don't see things clearly. Well, each eye sees it clearly. They see clear as night and day with each single eye. But guess what? When they put their eyes together, there's problems going on because their eyes don't seem to get that little coordination going on that keeps it together.
So Dr. Sharieff, I have a question on that slide. It's one thing that once the patient is in your office to ask these questions and to do these examinations, but for many of us attorneys, all we want to do is help our clients and do the best we can with the limitations that we are not doctors. So what are the types of questions we should ask to elicit responses that will help us identify that this client needs an evaluation by Dr. Sharieff?
So I have a symptom survey, which is a scale of 0 to 10, and there's a list of symptoms. So if you give that to the patient, and if they answer more than 2 or 3 on those symptoms, then they are being affected with their function in those areas. And that's the easiest way I can, give you one example. Like I said, I am going to also show you a 5-minute screening tool that is research-based, that is being done around the country. And that is going to be immensely helpful if somebody wants to do that. So there are 2 ways. One is the subjective symptoms. So the main thing is right now, whoever's listening is going to hopefully understand we're not talking about the eyeball or the eyeglasses for the clarity part of it, but everything else and their symptoms and how they're affected. So people will hopefully have a better idea in terms of understanding what the patient is saying. And then you can always administer that. I can have, I can give it to, the Injury Institute or Doctors Unlean, the copy of the survey. I can give it to someone. They are more than welcome to distribute it to whoever needs it. But also there is another screening tool that neuropsychologists, for example, who's been part of our Orange County Concussion Consortium, are very well versed on how to screen somebody for a concussion, for example. And 95% of that screening tool has to do with eye movements. So once I get to that, maybe it'll be a little easier to understand. Right now, I'm just going through the process of explaining, what exactly is going on with these patients and what they could be suffering with, so that you get an appreciation of where they're coming from and what's going on. And that survey, I could have actually taken a copy and put it up here, but I thought I'll just go through each and every symptom. That way it'll be easier. But I'll be more than happy to send it to you. Okay? Does that help you?
Yeah, it kind of, we're attorneys, not lawyers. So for most of us, what we're looking for is, legal liability questions, answering legal liability questions, and making sure that we do offer the services the client is looking for.
Correct.
And, so as we go through our intake process, it's going to be a lot less scientific than a medical intake. So it'll be something more along the lines of, what type of trauma did you sustain in the accident? What are your symptoms? Where do you have pain? Putting together a whole intake that would be specific to neuro-optometry is interesting. And I'm curious, at what point most attorneys do such intake protocols. But I can tell you, for me, as I go through my practice and I think about implementing this, is for us, most of our questions are going to be very much more simple. And I wonder if you have more simple questions, which is, do you experience any blurry vision? Do you have any sensitivity to light? What other questions would you put in a very quick, you're on a phone call with a person doing an intake type of questions?
Right. Like I said, it's just a one-page, it's just one single page.
Okay.
All the symptoms are listed. The first one is headaches, okay? The second one says photosensitivity. The third one says phonosensitivity. Do you have balance problems? Do you have vertigo? Do you lose your place while reading? Do you have, double vision? So it goes into layman terms.
Okay.
And if you just give it to the patient, when they come into my office, that's what we do. Hey, can you just grade this on a 0 to 10, all these symptoms? That's it. It's very simple. It's
All right.
in layman
Perfect.
terms.
I look forward to seeing this document. I'm sure all
Sure,
of
sure.
our
I've given it to Nicole from Injury Institute. I've given her a copy of that. So, but I will be happy to send it to you as well. Okay? It's really, really simple, and it's really easy to administer. It's not going to be very involved. One of the symptoms that patients also complain is, when they go to Walmart, for example, with all the activity going on, they're not able to keep their focus and attention to going to a particular aisle, picking out that particular object, what they need, and come back. they're going to be completely distracted. They cannot tolerate, so they get disoriented in market or malls, and they're bothered by, for example, a busy carpet like this. They just cannot multitask, they can't tolerate. I'm just kind of giving you some of the symptoms that you can easily pick up in terms of if it's a brain injury, that they are going to be giving you all these symptoms that you can probably, understand and appreciate that they are really suffering with a brain injury. Um, and in more severe cases, you know, there now, do you think personally, like your own practice, do you see more severe trauma patients, do you think, with an actual car accident and they've been in a coma or they've had a serious injury? Do you
I
think you,
actually have a case right now that's right in line with this, which is our client's vision actually goes in and out. So she has periods of time where one eye will just see black. I have other patients, with neurological workups and, positive findings on the MRI and sensitivity to light, vertigo issues. We do see that.
okay,
I will say that for many of them, when they first came in, these were not their initial complaints. And they weren't their initial complaints, not because they weren't experiencing them, but more so because they didn't recognize how serious they were at the beginning, that they thought, maybe it's just stress, the fight or flight response with adrenaline. And, a week after the accident, they come back to us and they say, that vertigo I was experiencing hasn't gone away. Is that something, they ask us, is that something that's related to the accident? Um,
so
yeah, go ahead.
yeah, so persistent post-trauma vision syndrome, usually these are symptoms that are persistent and they're not going away. A lot of times the MRI is clear, the CT scan is clear. I mean, they may not show anything, you know, wrong with them, but you will see that most often than not, they will come back with persistent, issues. And yes, vertigo, yes, balance issues, I mean, memory issues, they can't recall words. All that is part of a TBI. So,
And
absolutely.
how do you fix it? What is your protocol for resolving these issues, such as, you know, vertigo, experiencing vertigo, vision coming in and out, sensitivity to light? What is your role in resolving these issues?
So, first of all, we have to get detailed analysis and measurements, right? So, that's what I'm going through right now. These are the areas we look at. Once we get all the data in, so because we're evaluating the brain, we're looking at, the eyesight, we're looking at the eye health. Then we're doing a functional evaluation, the tracking, the focusing, the eye teaming. We do an electronic eye movement recording to see how their eye is behaving and tracking, how their comprehension is. And then we also see the spatial orientation. And then we also do a visual processing evaluation. It's a, I mean, paper pencil task. Can they look at things? Can they make sense of it? So we go through another series of testing with that. And then we may also do the strength of the signal from the eye to the brain. So our first step is, let's evaluate how the eye-brain connections are and how are they functioning and are they deviating from the norm. Once we get the global picture, then we evaluate and then we treat them with lenses, with prisms, with filters, and with therapy. So those are our four main areas of treatment. Is we use tools and we work with the patient to give them a sense of, normalcy by reorienting or improving, with therapy. A lot of people may need therapy in order to challenge them. It's kind of like physical therapy for the eyes and the brain. So we have our own tools to do that. But initially we have to make them feel grounded. We have to make sure that, the input to the brain is as less burdensome to them. So they may need the initial prism, the initial glasses. We kind of have to make them in such a situation that now they're able to be challenged. Otherwise, these concussion patients especially are overwhelmed and they react pretty dramatically to little things. I mean, we've had patients where We had to walk them with two people holding them back to their car. It's a concussion patient. It's not like they had a stroke and they can't move, but mentally, psychologically, people are so affected with this that we have to be very gentle with them, and we have to introduce certain things, but we have to challenge them back to normalcy. And we have amazing tools, amazing tools that allow us to arrange experiences for them to be in a program in such a way that we sequentially build this up for them. So I didn't go over this initially in detail, but I've actually had to do 2 fellowships in order to learn all about the lenses, the prisms, and how it affects us, and what kind of therapeutic techniques are available in my first fellowship. And then my second fellowship goes more deeper into neuro-optometric rehabilitation, and how so it's a lot of, there's a lot of information that we take in, and we devise a treatment program.
So a
So
couple comments. Number one, it sounds like you're incredibly qualified and you have an absolute passion for the work, and it's beautiful. The question that I'm getting over and over again is, do you do all of this wonderful work on a lean from beginning to end?
yes, I do.
Okay. Thank you for that, because that's the question, because it seems like a lot of people are eager to work with you and learn from you. And it's great to know that, you take lanes and can help everyone.
Yeah, I mean, I used to have, I don't know if I still have it, but I've had lean patients come into my office, they cry, especially people who have more demands, like a manager, and how they're not themselves, they can't function, but they're expected to, and they break down and cry. And there was this one lady, I still remember, and then when I did her first progress evaluation, she was so brilliant in the way she was explaining this. So I was like, can we film you? Because you're just being so expressive in how much this has helped you, especially when you came in, how you were. So we actually did film her. And we had it on my website. I don't know if it's still there, but, and she was on a lean. So, and our goal is to get people back to, normal life again, whether it's on a lean or not. I mean, they're all people, right? So we just do our best to work, and we've been very fortunate. I think this afternoon I've been working maybe, I don't know, maybe 3-4 years, in this field. And for the first time this afternoon, my office manager called and said that there was a case that failed. That was the first time. But we've never had any, we've had a really good group of, attorneys and our team, that we've been working with. And we try and work with, getting the work done. And
Okay,
we've
so
not been dissatisfied.
we have
Okay.
a few more minutes left, and I want to make sure to get through all the questions. So I don't know, you want to go through questions, or you want to finish your slides in the next few and leave a couple minutes for?
I will go really fast because
Okay.
this is kind of important, okay?
Okay,
So
go.
visual midline just means that anatomical midline and what happens after a brain injury is distorted and they go off balance. So we have a way to test them. This is extremely critical, and we can reorient their midline with yoked prisms. It's very dramatic, and it really improves their posture and their balance. So it's anterior, it can be lateral or anterior posterior. And there is a link between vision and posture. It's extremely valuable. And this is just a balance test that I have them, and we can quantify, we can use prisms and lenses to see if it'll help them or not. So we have objective ways to evaluate, and it's, graphically, it gives us information as well. So as, about their balance. This is just a test to measure the strength of the signal and to see if our optometric intervention is going to be helpful with filters or prisms or binasal occlusion. So objective measurements, we put electrodes, visual evoked potentials. This is an electronic eye movement recording system that actually lets us know how the right and the left eye, sometimes they're tracking okay, sometimes it goes like that. I mean, they're like, you can see how they're struggling. It is unbelievable. So we can see what's going on in the brain, how their vision is being coordinated, because the brain is doing all the work. The eyeballs are just like, it's just a conduit, basically. It's capturing data, but it's giving to the brain, and the brain is the one that's doing the work. So we have an analysis here, a graphical analysis that says fixation per 100 words, regression. So we get the quality of their eye movement when they're reading. We also get a comprehension thing on that. You asked about objectivity, so I wanted to go through that really quick. And one of the things that I really, really need to focus, kind of make you guys, relay this information is a lot of people have laterality and directionality concepts. The right and the lefts are mixed up. They can't integrate, their eye-hand coordination. So they can't understand subtle differences. They have visual memory. So it's not just physically eye tracking, but how they're analyzing that information and how they're able to multitask. So that, can really make them, and we address that. We have a way to test this. I can't go into detail about how we test everything, but we test it and we treat it. So there is, vision is dominant, but must remain plastic in order to support posture. I talked about the ambient vision is critical for spatial organization, posture, balance, and movement. Any compromise will affect the plasticity and ultimately, their function. Very quickly, these are research-based. Mayo Clinic has done the King-Devick, there's a whole thing on that. It's just reading numbers. VOMS is what I really wanted to talk about. I know you guys, attorneys, don't have time to do this test, but if there are any, like neuropsychologists do this or any other physicians, this is available on, you can Google this. It's called VOMS. This is done on the sideline on all, throughout the country. People are suspected like a concussion, they're pulled out, they're administered the worms. All that it is they do some tracking and, these techniques, and after each task, they ask, do you have headache, dizziness, nausea, fogginess? So they grade this on 1 to 10. So this all is available, it's research based, and if they fail the worms, then they're pulled out. And so a concussion is diagnosed based on the worms. And there's a neuropsychologist that used to refer to me a lot because she used to do the worms, and they'd fail this like convergence stuff, near point of convergence. When you bring the near point in, the one eye goes out, and that really, so that's part of the test. And like I said, I don't want to spend time on this because it's available online. Anybody can Google worms, and anybody who wants to know if this patient has had a concussion, it takes 5 minutes. This is the whole score, and you can be assured you are screening someone for a concussion. If they fail, they can come to my office also, So because 95% of this is to do with the eye movements. That's why neuro-optometry is on the forefront now in the rehab world, and everybody is looking into this field, for help in terms of helping their patients. This is a video. I don't think I have time for this now. That, is very dramatic, but maybe if I would do it in person and we have time, we can do that. But, vision problems in concussion are missed by optometrists. Unfortunately, almost all my colleagues, nobody has heard of neuro-optometric rehab. So the optometrists, the general optometrists you see, in this world, in any place, they have no clue about concussion, so they're also not going to pick it up. The physicians, the neurologists, unless they've been in the concussion world and learned about it and kept up on this, everyone's missing this. So it's just a small group in the hospitals and the rehab world that they know about neuro-optometry, and they're passionate about getting help for their patient, and those are the people I work with. So this is just a busy slide, but it's the same things that I've told you before. There's nothing new, so I'm not going to go through it. There's a lot more behavioral signs, So again, it's repetition of everything. Like I said, loss of attention, memory, stamina, behavioral issues, depression, anger, all frustration because they know something's wrong, but you don't know what's going wrong. How are you going to fix it? That's why the frustration increases. And I will end with this note. When you look at this picture, you can see clearly that it's black and white, but can you understand what this picture is about? What do you see when you look at it? Can you tell me, please?
I see a woman looking away.
Okay, so, I'm sorry, say that again?
I see a woman looking away, looking into the distance.
And what age group do you think that woman is?
I'd say late teens, early 20s.
Okay. Do you see an older woman too? Someone probably in her 60s or 70s?
Yes, I can see that from a different angle, yes.
There you go. So that's visual perception, which is different than looking at the object and looking at the black and white. So when people think about optometry, they're only thinking about, oh, can they see the black? Can they see the white? But that's not, in order for you to, have proper, efficiency with your brain, you need to be able to analyze what you're seeing, and that's part of the thing that's really missed quite a bit also. Okay?
Okay, so I
So,
have a few questions I want to go through, and some people are really hammering me with these questions. So number one question, where are you located and how fast can people get in to see you?
so I'm located in Orange County. We have two locations, Yorba Linda and Tustin. And we are open pretty much 6 days a week.
Okay, I want to make
And
sure I'm getting, a lot of people want to send patients to you, so let me go ahead and try and do this. What is your phone number?
714-996-6210. Also, they can look up visionperformanceoc.com, and that's my website and has my contact information.
I added your phone number to the screen. So the next question is VOM okay to use for an evaluation for a concussion, even if you're not a physician?
Athletic trainers do it. So all that you're doing is you're screening someone and you're getting help.
Yeah, I'd say it's
So
not going to come in at trial, but it's a good way to screen. Is that a fair way to put it, Dr. Sharieff?
yeah, it's research based, like I said. And currently, athletic trainers are the starting point. So it's not a physician. So as far as I know, you're just following the guidelines and screening. So I would say that it should be perfectly fine to initiate that.
Okay, so question number two, I'm going to consolidate because I have multiple questions here. If a client is seeing blood in an eye or is blacking out in an eye, what is the treatment plan, or how does your office handle that?
We will work with, a physician to make sure there is no pathology. When somebody comes in, we do a comprehensive exam. If we suspect a pathology, then we will refer to the appropriate person to make sure that there is no physical or structural damage, because that has to be addressed before we can continue any of our functional evaluation. Does that help you?
Yes.
Well, from Legal Lean Alliance, we want to thank both of our panelists so much. This was such a great informational webinar. We want to thank you, Justin Ferrari from Ferrari Law, and of course, Dr. Kauser Sharieff from Vision Performance Optometric Center. And we want to thank you all for attending. So please join us again. We're having another webinar on October 20th. That's all to do with TMJ. And you can register at our Legal Lean Alliance Instagram. So thank you again. Thank you to our panelists so much for sharing with us today.
Thank you for having me. Thank you, Dr. Sharieff. It was a pleasure.
Sure, you're very welcome. You take care.
Have a great night.
All right, you too. Bye-bye.